In this e-textbook of echocardiography in congenital heart disease, we are planning to start introducing the various echocardiographic views in this first module. This module will discuss about all the standard echocardiographic views that are used in imaging of congenital and structural heart diseases. The first view to start will be from the Subxiphoid view. We invert the image because this will correspond to the anatomical view of the heart. So this will also be called as anatomical imaging. So in the Subxiphoid coronal plane imaging, which is also called as the long axis view, we see on the left side of the screen the liver, the right dome of the diaphragm. On the right side of the screen, we see the highly echogenic stomach. Posteriorly, we will see the rounded echogenic spine. Just anterior to the spine, there will be two blood vessels. The blood vessel on the left side of the screen is the inferior vena cava, and the blood vessel on the right side of the screen is the abdominal aorta. When we interrogate the two blood vessels with color Doppler, we will identify the systolic flash of red color in the abdominal aorta, and the inferior vena cava will have a low velocity continuous blue flows. We can also notice that the inferior vena cava is a bit closer to the transducer and the abdominal aorta is farther away from the transducer. This is an indicator that the inferior vena cava is at an anterior plane to the abdominal aorta. When we sweep the transducer a little superiorly, we will see the hepatic veins converging towards the inferior vena cava. The normal inferior vena cava and hepatic veins should have an inspiratory collapse. As we see further up, we start noticing the two atria, the left atria and the right atria, the intraatrial septum between the two. The pulmonary veins from both the sides will be seen entering the left atrium. With color Doppler, we can appreciate the color flows from the pulmonary veins into the posterior wall of the left atrium. On a further anterior sweep on the same coronal plane, we can notice the superior vena cava entering the right atrium. The flow of blood from superior vena cava to right atrium can be seen well when we use color Doppler. After having gone through the Subxiphoid view in coronal plane sweep, which is the long axis sweep, now we move on to the short axis sweep. Here, we keep the probe in sagittal plane. We'll be able to appreciate the entire length of the inferior vena cava as it enters the right atrium. We notice here that there is a good inspiratory collapse of the inferior vena cava. We can appreciate the low velocity color flows in the inferior vena cava towards the right atrium. As the probe is kept almost perpendicular to the plane of the blood flow, we will not be able to appreciate much of the color flows. On this Subxiphoid short axis view, when we tilt the probe towards the heart, we start visualizing the right upper pulmonary vein draining into the left atrium. With color Doppler, we can appreciate the color flows from the right upper pulmonary vein into the left atrium. We can also notice the end-on view of the right pulmonary artery just posterior to the right upper pulmonary vein. After visualizing the right upper pulmonary vein drainage into the left atrium, on the same sagittal plane, If we make a little leftward sweep, we can identify the right superior vena cava entering into the right atrium. On color Doppler, we can confirm the flows from the right superior vena cava into the right atrium. Once again, notice that the end-on view of the right pulmonary artery is seen immediately posterior to the right superior vena cava. We can appreciate the entire intraatrial septum between the left atrium and the right atrium. When we visualize the inferior vena cava right atrial junction, on the anterior lip of the inferior vena cava, we can see the small remnants of Eustachian valve. In some of the hearts, these remnants may be very prominent. The arrow points to the location of the Eustachian valve. Immediately below the superior vena cava right atrial junction, we can see an anterior projection of the right atrium. This anterior projection is the right atrial appendage. From the plane of the atria, if we sweep further to the left in the same sagittal plane, we will start appreciating the ventricles. We will first appreciate the left ventricular outflow, where the left ventricle continues through the aortic valve into the ascending aorta. When we visualize the left ventricular outflow tract, where the aortic valve leaflets are seen, a small area of the membranous septum is visualized. The membranous septum is the part of the intraventricular septum which is located immediately below the aortic annulus and in close relation to the anteroseptal tricuspid commissure. This membranous septum is shown in this short axis view with a small arrow. We can see the freely mobile anterior tricuspid leaflet. The septal leaflet is mostly sort of tethered to the intraventricular septum, and the arrow points to the anteroseptal commissure. The region of the ventricular septum, which is in very close relation to the anteroseptal commissure of the tricuspid valve, is the membranous septum. When we further sweep towards the left, we start seeing the right ventricle continuing as the right ventricular outflow tract. The infundibulum, the pulmonary valve, and the main pulmonary artery all are seen in a line. With color flow interrogation, we can notice the flow from the right ventricle towards the right ventricular outflow, which is away from the transducer and hence coded blue. Within the cavity of the left ventricle, we can appreciate the mitral valve with its anterior mitral leaflet and the posterior mitral leaflet. The two commissural areas are also seen. On a further leftward sweep, we can start noticing the two papillary muscles, the anterolateral papillary muscle and the posteromedial papillary muscle. On a further leftward sweep, we can see the apical parts of the ventricles. Now we move on to the apical view. The apical view is best obtained by clinically palpating the apex of the heart and keeping the transducer over the apex. Ideally, the transducer should be placed on the most apical part of the left ventricle. We can appreciate the four chambers of the heart, the mitral and the tricuspid valves. From this plane, when we sweep very posteriorly, we'll be able to appreciate the small coronary sinus that drains into the right atrium. The coronary sinus appears as a small parallel track. In most of the grown-up patients and adults, the coronary sinus will be measuring around 9 to 10 millimeters. In small babies, it will be proportionately smaller. The method of identifying the coronary sinus will be by seeing a parallel track of echolucencies. We need to understand that we'll be able to appreciate the coronary sinus when we go posterior to the plane of the mitral annulus. From the apical view, when we start sweeping the transducer anteriorly, we start seeing the left ventricular outflow tract on the aortic valve. This is sometimes referred to as the 5-chamber view. When we do a color Doppler interrogation of the left ventricular outflow tract, we can notice the flow away from the transducer through the aortic valve, so coded blue. After the apical view, we move to the parasternal long axis view. The parasternal long axis view is obtained by keeping the transducer on the left side of the sternum. The probe should be in a plane along the long axis view of the heart. The long axis view of the heart passes from the base to apex. After getting the parasternal long axis view where we visualize the left atrium, mitral valve, left ventricle and the aortic valve, if we make a leftward sweep, we will start noticing the right ventricular outflow tract or infundibulum, pulmonary valve, continuing as the main pulmonary artery. Using color flows, we can appreciate the flows from the right ventricular outflow tract into the main pulmonary artery. A tiny amount of pulmonary regurgitation is commonly seen in most of the normal hearts. From the standard parasternal long axis view, when we sweep towards the left, we start seeing the pulmonary outflow tract. Instead of that, if we start sweeping towards the right, we will see the right ventricular inflow or the tricuspid valve. In this view, we can see the right atrium, the tricuspid valve and the inflow portions of the right ventricle. On this parasternal long axis view with a rightward sweep, when we visualize the tricuspid valve, we can appreciate the anterior tricuspid leaflet and the posterior tricuspid leaflet. The anterior tricuspid leaflet will be a longer, broader leaflet. The posterior leaflet will be a smaller leaflet. We can measure the tricuspid annulus in this plane. To visualize the other tricuspid leaflet, namely the septal tricuspid leaflet, we go back to the apical view. On apical 4-chamber view, we visualize the anterior tricuspid leaflet and the septal tricuspid leaflet. After the parasternal long axis view, we move on to the parasternal short axis view. In the parasternal short axis view, we keep the marker on the transducer towards the left shoulder of the patient. We can appreciate the tri-leaflet aortic valve and the left ventricular outflow tract in the center. Posterior to the aorta will be the left atrium and anterior to the aorta will be the right ventricular outflow tract or right ventricular infundibulum. We can notice the right ventricular outflow tract, the pulmonary valve and the main pulmonary artery wrapping around the left ventricular outflow tract. When we visualize the aortic root, we can notice the left coronary artery arising from the left aortic sinus. It branches into an anterior left anterior descending coronary artery and a posterior left circumflex artery. If we do a color Doppler interrogation of the coronary arteries with the usual Nyquist limits, we will not be able to appreciate any color flows into the coronary arteries. However, when we reduce the Nyquist limits to very low levels, we will be able to appreciate the color flows in the left coronary artery and left anterior descending coronary artery. From the anterior wall of the aorta, we can appreciate the right coronary artery taking off from the right aortic sinus. On a parasternal short axis view, after we visualize the aortic root, if we make a tilt towards the apex, we will be able to cut the left ventricle at the level of the mitral valve leaflets. We can appreciate the anterior and posterior mitral leaflets, the two commissural areas, the anterolateral and the posteromedial commissures. On a further downward sweep in the same parasternal short axis view, we can appreciate the two papillary muscles, the anterolateral and the posteromedial papillary muscle. On a further sweep downward, we can see the apical portions of the ventricle. These areas will be devoid of the papillary muscles because we have come to a plane much more apical than the plane of the papillary muscles. On the parasternal short axis view, from the level of the left ventricular outflow tract, if we start sweeping superiorly, we can appreciate the right ventricular outflow tract continuing as the main pulmonary artery. Further superiorly, we can appreciate the main pulmonary artery branching into the right and left pulmonary artery. The right pulmonary artery will be coursing posterior to the ascending aorta and the superior vena cava. The left pulmonary artery will be moving to the left, anterior to the descending thoracic aorta. In the left first intercostal space, if we keep the probe on a sagittal plane, more in alignment with the long axis of the heart, we will notice the main pulmonary artery continuing as the left pulmonary artery. This view is called as the ductal view since the patients with ductus arteriosus will show the patent ductus in this particular view. This ductal view will be explained in detail in the module on PDA, which you will come across later in this textbook. We were showing in the Subxiphoid short axis view how to identify the right atrial appendage immediately below the right superior vena cava right atrial junction. In the same way, a left atrial appendage can be appreciated on the parasternal short axis view on the left side of the aortic root. Posterior to the aortic root, we can appreciate the left atrium. The left pulmonary veins will be draining on to the leftward side of the left atrium. The left upper pulmonary vein is an anterior structure and the left lower pulmonary vein is a posterior structure. So the color coding of the upper and lower pulmonary veins will be blue and red respectively. We need to understand that both the left upper and left lower pulmonary vein will be seen to enter the left atrium on the left side of the descending thoracic aorta. The descending thoracic aorta, which is seen here circular as an end-on vessel, is a posterior structure in the mediastinum. On the right side, we can appreciate the right pulmonary veins draining into the left atrium. From the parasternal short axis view, we now move on to the suprasternal view. This is a suprasternal long axis view showing the ascending aorta continuing as the arch and descending aorta. The arch of the aorta continues as the descending thoracic aorta. The portion of the aorta immediately after the left subclavian artery is called the isthmus of the aorta, and it is of significance in diagnosis of patent ductus arteriosus and coarctation of aorta. On the outer surface of the aortic arch, we can notice the normal origin of the arch blood vessels. The first branch will be the innominate artery, The second and third will be the left carotid and left subclavian artery. We can appreciate the color flows into the arch vessel branches. The first branch being the right innominate artery, the second and third being the left carotid and left subclavian artery. With color Doppler, we can also appreciate the normal systolic flow in the arch of the aorta and descending thoracic aorta. On a suprasternal short axis view, if we keep the probe in coronal plane, we will be able to see the entire length of the right pulmonary artery posterior to the ascending aorta and the superior vena cava. On this suprasternal view, when we keep the transducer in coronal plane and sweep the transducer posteriorly, we'll be able to appreciate the arch of the aorta falling back on the left side of the trachea as the descending thoracic aorta. And this will confirm that the arch is on the left side. The first branch of the left aortic arch is the right innominate artery, which branches into right carotid and right subclavian artery. The arrows point to the right innominate artery and then it's branching into the right carotid and right subclavian artery. With color Doppler, we can appreciate the color flows into the innominate artery. In the suprasternal view, the solid mass of tissue that is seen around the arch blood vessels and immediately anterior to the distal ascending aorta is the thymic tissue. With the description of all these views, starting from subxiphoid coronal plane cut, followed by subxiphoid sagittal plane cut, then moving on to apical four chamber view, and then the parasternal long axis and short axis view, and finally terminating in the suprasternal view, we will be appreciating all the cardiac structures that are important in assessment of any congenital or structural heart disease.